Okay, this is the second part of Unit 6 in micro, and we're going to talk about antibiotics. Um, in micro, we refer to the antibiotic testing as susceptibility testing. Um, we start out with terms, antiseptics, antibiotics, disinfectants. They all are used for not only bacteria but fungus too. um, Antibiotic resistance, it refers to when the antibiotics are not able to kill the bacteria. It's associated especially with overuse, overprescribing of doctors for antibiotics that are not necessary. Viruses are not supposed to be treated with antibiotics, and that's a lot of times the case. Um, the antibiotics work all in different ways. They're set up into different classes, and they're in those classes according to how they work. So the mechanisms are the different things that they do. Some inhibit cell wall synthesis, some inhibit folate synthesis, some interfere with DNA replication and transcription, and messenger RNA translation. And the end result for all of these is that the bacteria cannot survive without these things remaining to go on. Okay, I want you to make sure that you know which ones are in each class. For example, you may see a question that says, which of the following inhibits the cell wall synthesis, and your answer is going to be cephalosporin or one of the cephalosporins that are listed in your notes. So this is kind of a little summary page that's not in your notes. The ones that inhibit cell wall synthesis are the beta-lactams like penicillin, ampicillin. The cephalosporins, I think all of these start with a C. The ones in your notes are, but that's like ceftriaxone. The glycopeptides also inhibit cell wall synthesis, and this is like vancomycin. The folate synthesis is trimethoprim. DNA replication are the quinolones and the fluoroquinolones, and this is the examples are Cipro, Levaquin, nalidixic acid. The ones that inhibit or interfere with protein synthesis are the aminoglycosides like gentamicin, tobramycin, the tetracyclines, the macrolides like erythromycin and clindamycin, and chloramphenicol. Okay, the beta-lactam, these are the ones that inhibit cell wall synthesis, and we're going to start out with the beta-lactams. These are the penicillins, the cephins, the carbapenems, the monobactams. These will bind to the proteins of the beta-lactam ring in the bacteria to destroy it. The examples are penicillin G, penicillin B. These are both naturally made. If you remember, these come from the fungi Penicillium. They're for gram-positive cocci. Ampicillin is an extended spectrum drug, and what that means is it's for different types, a wide variety of organisms. They're not for organisms that produce beta-lactamase. They're for gram-positives and gram-negatives. Penicillin co-drugs. So what happened was the organisms became smart, and some of them developed an enzyme to break down the penicillin. So the ones that have the beta-lactamase are resistant to penicillin. But pharmacies came up with a co-drug like Augmentin. Augmentin is amoxicillin with clavulanic acid or clavinate potassium in it. And the clavulanic acid is there to inhibit the beta-lactamase. So these have to be used for beta-lactamase inhibitor in producers. And also, it's important for you to know that Strep pyogenes is considered universally susceptible to penicillin. We don't usually do susceptibility testing on Strep pyogenes. It can automatically be treated with penicillin. Okay, the CEPHMs or cephalosporins, these are set up into different generations, and as of now, the all the way up to the 5th generation has been created. These are similar to penicillin, but they are better against beta-lactamase, and the first generation is a narrow spectrum. That means that it's only used for a certain select organisms. The ones that are in that group are listed there. You need to make sure you know those. They are for gram-positive cocci, but not Enterococcus and MRSA. The second generation was expanded to include more organisms. So it's good for gram-positive cocci also, but more for Enterobacteriaceae too. The third generation has even more activity for gram-negative rods. It's good for beta-lactamase producers. It's usually used in nosocomial infections and multi-drug resistant gram-negative rods, like the E. coli and the Klebsiella that have become really resistant. The fourth generation, it may not be in your notes, so jot this down. Cefepime is one of the ones in the fourth generation, and it's very similar to the third generation. And the fifth generation has not long been even developed, maybe within the past year or two. Okay, also glycopeptides, this is like vancomycin, and there's more in these groups. You don't have to learn them all. Vancomycin is a narrow spectrum. It's only used for gram-positive cocci and usually MRSA, strep, and Enterococcus only. To inhibit folate synthesis, the trimethoprim is used, trimethoprim sulfa or any sulfa drug, and these are used for Enterobacteriaceae in urinary tract infections. Okay, the quinolones and fluoroquinolones inhibit DNA replication, and they target the DNA gyrases, which are enzymes. They're used for Enterobacteriaceae, Pseudomonas, Staph, Enterococcus, Neisseria strep, but not Strep pneumo. Strep pneumo is has become kind of resistant over the years. It's used for complicated UTIs and ear infections. Complicated UTIs are when patients have more than one organism. Examples are nalidixic acid. That's typically just for the treatment of UTIs. Cipro, levofloxacin, and gadafloxacin, and Levaquin is levofloxacin. Okay, protein synthesis. The aminoglycosides, which includes gentamicin, amikacin, tobramycin, neomycin, and streptomycin. Gentamicin is used for many nosocomial infections, and tobramycin is often used to treat Pseudomonas. Pseudomonas is a very resistant organism. Often these are combined with other drugs. It's not used for anaerobes. There are certain things that can happen if this drug is used in too high of a level. It can damage the kidneys and the ears, and serum has to be drawn to closely monitor the levels with especially gentamicin and tobramycin. Also tetracyclines, doxycyclines, minocyclines, these are broad spectrum, so they're for all kinds of organisms, gram-negatives, gram-positives, even mycoplasma and chlamydia. The macrolides include erythromycin, clarithromycin, clindamycin. These are also broad spectrum. Erythromycin is used when patients have penicillin allergies, when they have infections with strep pneumo and strep pyogenes. Clindamycin is used for gram-positives, for gram-positive cocci, MRSA, Enterococcus, and most anaerobes. Chloramphenicol is usually used for serious gram-negative infections like typhoid fever, salmonella, cholera. It's can be almost dangerous to a person because it can cause bone marrow aplasia. So the patients can become anemic, leukopenic, and even the platelets can be decreased. Recently FDA approved ones. When I say recently now, this is probably the last 8 to 10 years. For VRE and MRSA, there were so many drugs that were becoming resistant that the pharmaceutical companies were trying to come up with some, and Linezolid and streptogramin were invented to help treat MRSA and VRE. Okay, the antifungals, amphotericin B, clotrimazole, Lamisil, and diflucan. The viral ones, in your notes it says amantadine. That used to be used for the flu, but it's not anymore, so you can just take that out of your notes. It was proven that patients did not get any better with the use of that medication. Vidarabine is for herpes. AZT is for HIV. It's supposed to slow down the replication process. Relenza and Tamiflu are used for the influenza virus now. The antimycobacterial drugs for TB are listed there. Make sure you know those. The factors to consider when deciding what kind of medication a patient is supposed to be on is where is the organism at. For example, if they have meningitis, it has to be an antibiotic that will cross the blood-brain barrier and get to where the patient has the infection. Is there more than one pathogen? Because the patient needs to, it's more reasonable to put them on one antibiotic that will treat both of the infections at once. Also, the immune status of the patient. Normal flora may be a pathogen. That's, up to the doctor to decide. And also, I listed allergies because there's a lot of patients that are allergic to different antibiotics, especially penicillin. Okay, selecting antibiotics. We have standards from the Clinical and Laboratory Standards Institute, and these are usually in one big notebook, and they are arranged in there according to body site, test method, and organism. as to what antibiotics are going to be tested for. There is no way that we could possibly test for all the antibiotics that exist. So usually a class representative is tested. For example, we may use amoxicillin to represent all the ones in that class. And if that is sensitive, then you can assume that the other ones in that class are sensitive too, and they can be used. Testing is formulated by the microtechs, the infection control, the pharmacists, and the clinicians. So they get together and they decide which ones the pharmacists are going to keep in-house. There's no use in us testing for antibiotics that pharmacy is not even going to have. So it's not just a simple little process. We're going to test for this, this, and this. It's very there's a lot of research that goes into what antibiotics are tested for. Okay, the terms that you need to know. S is usually put beside the result to stand for susceptible. That means that the organism is susceptible to the antibiotic and it kills it and it can be used for treatment. Resistant with an R, it can't be used. Intermediate, there's always an intermediate range in which the organism is not resistant or not susceptible. It's in the middle. And these can be used. They're not used very often, but if they're used, they have to be used in a higher dose or in combination with another drug, or if it can be put directly on the infection site, like as a cream or something. The MIC is the minimal inhibitory concentration. The MIC is the number that we report out. This is the lowest concentration of an antibiotic that inhibits the organism. The MBC is the minimal bactericidal concentration. This is the lowest concentration that the antibiotic will kill the organism. So the MIC is the level that the antibiotic inhibits it, and MBC is the level that the antibiotic kills it. Now let me explain what that means exactly. So these are dilutions of antibiotics that are set up. This has 0.5 of the antibiotic in a solution, and the bacteria has grown, and how we would know is it would be cloudy. So the first tube that looks clear is the MIC. So this MIC is 8. It inhibits it. How we find out the MBC is we subculture it, and they have subcultured this one and it grew. So there really is actually something growing in there. We subcultured this one to a plate and no organisms grew. So this has killed the organisms for sure. So this is the MBC. This has inhibited the organism. We can't tell that it's in there, but there are some. And this has killed the organisms, and there are not any there at all. And also the SBT is the serum bactericidal testing. This is actually done usually in endocarditis, and when a patient is on antibiotics, what we do is just draw their serum, draw their blood, and culture their serum to see if anything is growing. Okay, testing procedures. The first thing that we have to do is make an inoculum. The inoculum is just some saline or broth with the organism in it like this. And you've done this before, I think. You add fresh colonies. They should be 18 to 24 hours old in order to get the correct results. The McFarland turbidity standards are used. The most common one is the 0.5 McFarland standard, and that's equal to 1.5 times 10 to the 8 colony factoring units per milliliter. So you just put some organism in there and you compare it to the standard. If it is too thick, too dark, too heavy, you add more saline or broth. If it's too light, you just add more organism. So this can be prepared visually like this to see if it's the same turbidity. And there's also little small devices that can be used. And you just simply put this in a tube holder and the device will read it nephelometry or spectrophotometry and tell you what the McFarland standard is. And they're really nice and easy to do. Okay, in almost every antibiotic panel that we do these things. This is a purity check. That's to make sure that the bacteria is not contaminated. So what we would do is just like, if this is our sample, our inoculum, we would culture that to make sure that only one organism is in this tube. Nothing else is growing. A growth well, the growth well is in the panel and there's no antibiotic in there, and that's just to make sure that the organism will grow in the broth that's in the antibiotic panel. Sterility check to make sure that the panel's not contaminated, and we constantly do QC on the antibiotic panels every week. Every week you do a certain organism, and we order these organisms from a company so we know what the antibiotic results are supposed to be, to check to make sure that we're getting what we're supposed to. Okay, dilution methods. We do varying concentrations. So these usually start out low and then they get higher with the antibiotic. The MICs are reported. Macro dilution refers to a big tube like this. A micro dilution is a small well like this one on this side. These can be frozen or freeze dried, and there's some that are even smaller than this that hopefully you saw in clinical or will see. Agar dilution is when certain volumes of the antibiotic are in the Mueller-Hinton agar and you sub the organism to it to see if it grows that way. Okay, so this is the first method that came about, and it's called the Kirby-Bauer disc diffusion. And this is what you done when we did staph. I think you should have set up a bacitracin and or a novabicin or PDIS. It's the same concept. So they're always done on Mueller-Hinton, and you make an inoculum and you streak the plate to put the organism on there. You add antibiotic paper disc, which are what these are, and then you incubate it and then you measure the zone. These are all different types of antibiotics on this one E. coli. So this is like amoxicillin and Cipro and Levaquin and whatever. Again, this is called the Kirby-Bauer method. The discs, the antibiotic discs, are should be FDA approved. They're stored in the freezer at -20 until the expiration date. If they're taken out and stored in the refrigerator, they're good for a week. and they need to come to room temperature before testing, and if you're going to freeze them, then you put them directly back into the freezer. Okay, the factors that affect the Kirby-Bauer results. The agar cation concentration, especially calcium and magnesium, they can affect the tetracycline and the aminoglycoside results. A lot of these things are taken care of in the agar now because we order it from a company. This used to be important when people prepared their own agars, and they had to make sure that all of these things are okay. If the cation concentration is too high, you'll get a false resistance. If it's too low, you'll get a false susceptibility. The agar pH needs to be 7.2 to 7.4. If it's lower, you can have a false result. The level of thymidine in the agar affects trimethoprim, the sulfa drugs, and trimethoprim sulfa. If it's too high with Enterococcus, false resistant could occur. With strep pneumo, you can't use the Mueller-Hinton that is clear like this. You have to have the Mueller-Hinton with blood or it won't grow. The agar depth, too thin of an agar causes a false susceptibility. Too thick causes a false resistance. The inoculum preparation, it's the most critical, and we still prepare the inoculum, so this is important in our day. If it's too heavy, it'll cause a false resistance. If it's too light, it'll cause a false susceptibility. Also, stacking the agar plates too high can cause a false susceptibility. Okay, special tests that go with certain organisms. These are organisms that have developed an antibiotic resistance over time. Strep pneumo has become resistant. Mueller-Hinton with horse blood or sheep blood has to be used. An oxacillin disc is used to check for penicillin resistance. So we sub the strep pneumo to a plate, and then we drop an oxacillin disc and check for the resistance that way. Haemophilus influenza and parainfluenza, a special Haemophilus media has to be used, and you have to incubate it in CO2. Beta-lactamase that checks for penicillin resistance has to be done on all of those isolates, and also with Neisseria gonorrhea and meningitis. A GC agar has to be used. It has to be put in the CO2, and beta-lactamase is done on all of those isolates, and that's to check for PPNGs, which stand for penicillinase producing Neisseria gonorrheas. They have to be treated with nitrocephin, which is a cephalosporin, if they're resistant. Okay, MRSA. These are Staph aureus strains that have acquired the MECA gene that causes them to be resistant. We check for oxacillin resistance, but if they're resistant to oxacillin, they're resistant to penicillin, methicillin, chloroxacillin, and dicloxacillin, and the organism is referred to as methicillin resistant. To detect it, we can do the oxacillin disc diffusion with a disc on a plate, the oxacillin screening agar that you just streak the organism on, and there's also the chroma agar that is used. But with these, instrumentation should be set up also. So two methods are used to confirm MRSA. Borderline oxacillin-resistant isolates usually don't grow on the oxacillin agar, and you'll be able to tell by the instrument results if it's a borderline. MRSA screening is done on the nares, which is the nose, in most hospitals when the patient is going to be admitted. Some hospitals only do this for ICU patients or surgery patients. Some hospitals do it on any inpatient. If a patient has MRSA in their nares or they grow it from a culture, they're put on contact isolation, which means the visitors are supposed to be limited, and you're supposed to wear gloves and a gown when you go in. A respiratory mask does not have to be used. Okay, VISA or VRSA. The VAN-A gene from VREs somehow were transmitted to the MRSAs and have caused VRSAs to occur. Now, there hasn't been too awfully many, but we still have to check for these. So not only do we check for oxacillin-resistant in Staph aureus species, we check for vancomycin resistance. We also check for vancomycin resistance for VREs, vancomycin-resistant Enterococcus. It's commonly seen in Enterococcus faecium, but also faecalis. There's screening augers and disc diffusion and instruments that can be used just as with the MRSA. Okay, the special test for staph. This is not just Staph aureus. This is Staph epi, this is Staph saprophyticus, and Staph aureus, and any other staph. So when we set up the antibiotic susceptibility on the instrument for a staph species, and the results say that the organism is resistant to erythromycin and sensitive to clindamycin, we have to do a D test to check for inducible clindamycin resistance. So what you do is streak the organism on a plate, you make an inoculum. The clindamycin and erythromycin discs are placed 15 to 26 micrometers apart. You incubate. If it's positive, there is a flattening of this zone, and it makes it look like a D. So it's called the D test. And staph has an inducible resistance to clindamycin in this. So this result from the instrument will say sensitive, and we have to go and change it to say resistant. Okay, ESBLs. This stands for extended spectrum beta-lactamase producers, and these are usually gram-negative rods, mostly Klebsiella and E. coli. They can inactivate the extended spectrum cephalosporins and penicillins, and these organisms have them too, and most of the instruments now will check for ESBLs. There's nothing special that has to be done, no backup test. This is not in your notes. This is called a modified Hodge test. This is done for Enterobacteriaceae, especially Klebsiella. Some of these gram-negative rods have developed a carbapinamase enzyme to make them resistant to carbapinamases. And that's what this stands for, Klebsiella pneumo carbapinase producing organisms. So I just want you to see, you don't need to know how this is set up, but you need to know that this is the name of it. It checks for this in this type of organism, and if it's positive, it gives a clover leaf like indention, like a clover indention, and this is a positive result, meaning that the carbapinums are resistant for that organism. And that's it. Let me know if you have any questions.